Welcome back to the deep dive. Today, we are completely clearing the decks. We are putting aside the casual curiosity and the general interest topics. We are shifting gears into what I like to call war room mode.
That's absolutely right. Today is strictly business. I'm stepping out of the role of just being an analyst and stepping into the role of your senior MD faculty, or maybe your external examiner, and you, the listener.
You are the postgraduate student, the resident sitting right in the hot seat.
Exactly.
We're treating this session as the ultimate exam cram for the MD anesthesiology examinations. We've pulled from the heavy hitters. We're talking Miller's anesthesia, Morgan and Mikhail, the big ICU protocols, and even the objective anesthesia review.
And our mission, if you choose to accept it, is to condense thousands upon thousands of pages of text into a single, comprehensive, high-yield audio guide.
Specifically tailored for the exams, right? Like the really rigorous standards you see at places like Gujarat University.
Precisely. And we're tackling the one topic that is practically guaranteed to show up. It is the absolute bread and butter of our field, yet it trips up so many candidates.
Why is that?
Because they think they know it, but they don't know it deeply enough. They don't know the physiology behind the numbers. We are talking about hypertension.
It sounds so basic on the surface. Everyone knows what high blood pressure is. But I take your point. In an exam context, just knowing it and being able to present it systematically are two very, very different things.
Worlds apart.
So let's start right there with the introduction. How do we frame this for an examiner?
You have to start with precision.
Yeah.
Immediately. If you are asked to define hypertension, you don't just say, oh, it's high BP. That's a fail.
You need the criteria.
You need to quote the standard. And for exam purposes, we stick to the JNC-7 criteria. So you'd say, sir, hypertension is defined as a sustained systolic blood pressure greater than 140 millimeters of mercury. Or a diastolic blood pressure greater than 90 millimeters of mercury. Be crisp. 140/90.
Okay, definition locked in. And it's not a niche problem, is it? What's the magnitude we're looking at here?
It's massive, genuinely massive. We're talking about a prevalence of 20 to 25% of the entire adult population.
Wow.
It is, without a doubt, the single most prevalent preoperative medical abnormality you will encounter in your entire career. In the exam, you need to use the key phrase for it.
Which is?
The silent killer.
Silent killer. That's a strong phrase. Why do we specifically use that one?
Because the patients are largely, almost completely asymptomatic until something breaks.
Until the damage is already done.
Exactly. Until end organ damage occurs. And that brings us to why we, as anesthesiologists, and more importantly, why examiners care so much about this.
It's not just about the number on the monitor.
Never. It's a surrogate marker for systemic vasculopathy. When you see that number, you should see stiff, damaged vessels.
So high BP means we should be thinking about organ stress.
Immediately. These patients have a significantly increased perioperative risk because they are, for lack of a better word, brittle. They're prone to ischemia, they're prone to arrhythmias, and most importantly, to profound hemodynamic instability.
The roller coaster.
The classic roller coaster. Catastrophic hypotension on induction, followed by a hypertensive crisis on intubation. That lability, that wide swing, is what kills.
Before we really get into the weeds, let's just map out the exam pattern. Where does this topic actually show up?
Oh, it shows up everywhere. It's unavoidable.
Yeah.
First, the long case. I can almost guarantee you will get a 60-year-old patient with uncontrolled hypertension posted for major surgery, and you have to clear them.
And in the written paper.
Theory paper, absolutely. Expect a solid 10, maybe 20-mark question. Something like, discuss the pathophysiology and anesthetic management of hypertension.
And of course, the Viva.
The Viva is where they really test your depth. They will grill you on the pharmacology of every single antihypertensive drug and, of course, the famous cancellation criteria, the 180/110 rule.
Okay, so it's everywhere. Let's build our answer from the ground up. Section 2, normal blood pressure regulation. The outline says this is very high yield.
It's beyond high yield. It's foundational. You simply cannot explain the pathology if you haven't mastered the normal physiology. Anesthesiology is, at its heart, applied physiology.
And it all starts with one equation.
Everything. The entire topic hinges on one fundamental equation. If you write this at the very top of your answer sheet, you are already winning. Blood pressure equals cardiac output multiplied by systemic vascular resistance.
BP equals CO times SVR.
Memorize it. Live it.
Simple enough on the surface, but we can break that down further, can't we?
Of course, you break down each component. Cardiac output is simply stroke volume times heart rate. how much blood per beat and how many beats per minute.
But for hypertension, the real story is on the other side of the equation.
That's where the examiner is hunting for you to go, the SVR side. Systemic vascular resistance is almost entirely determined by the radius of the arterioles. And this is where you must, absolutely must, drop the name of the law that governs this.
The Hagen-Poiseuille equation.
The Hagen-Poiseuille equation. You say that, and the examiner sits up. And you have to know the most important part of it.
Which is that resistance is inversely proportional to the radius to the power of 4.
The power of 4. That is the critical concept. It's not linear. It means that a tiny, almost microscopic decrease in the radius of a blood vessel causes a massive, exponential, fourfold spike in resistance and pressure.
So it's all about vascular tone.
It is the dominant driver of blood pressure. A little bit of squeeze goes a very long way.
So given how volatile that system is, how does the body normally keep it in check?
We have 3 layers of regulation, and you should present them in terms of speed: rapid, intermediate, and long-term.
Let's start with rapid neural control.
Correct. This is the baroreceptor reflex. You can call them the buffer system. They are stretch receptors located in the walls of the carotid sinus and the aortic arch.
And they work beat to beat.
Instantly. If your blood pressure drops when you stand up, they stretch less. This signal goes to the brainstem, which immediately inhibits parasympathetic outflow and ramps up sympathetic outflow. The result: vasoconstriction and an increased heart rate. Your BP is restored in seconds.
Okay, that's the immediate fix. What about the intermediate and long-term game?
That's where the hormonal and renal systems come in. And the big one here, the one every anesthetist must know inside and out, is the RAAS.
The Renin Angiotensin Aldosterone system.
Precisely.
Can you just walk us through that pathway again? It's where so many of our drugs work.
Of course. It all starts in the kidney. If the kidney, specifically the juxtaglomerular apparatus, senses low perfusion pressure or low sodium, it gets worried. It releases an enzyme called renin.
And renin starts a cascade.
Exactly. Renin finds a protein made by the liver called angiotensinogen, which is just floating around, and it cleaves it into angiotensin I.
Which isn't very active on its own.
Right, it's a precursor.
Right.
Then, as angiotensin I flows through the lungs, it encounters another enzyme. This is the famous one.
ACE.
Angiotensin-converting enzyme, primarily found in the pulmonary capillaries. ACE converts angiotensin I into angiotensin II. Now, angiotensin II is the real heavy hitter.
Okay, so what does angiotensin II do?
2 main things. First, it is one of the most potent direct vasoconstrictors in the body, so it directly cranks up SVR.
It tightens the pipes.
Viciously.
Yeah.
But second, it travels to the adrenal cortex and triggers the release of another hormone, aldosterone.
And aldosterone works back on the kidney?
Yes, it tells the kidney's distal tubules to reabsorb sodium, and where sodium goes, water follows. So angiotensin II tightens the pipes, and aldosterone fills the tank.
So you get increased resistance and increased volume, a double whammy for raising blood pressure.
And that's the system. It's a beautiful, elegant feedback loop designed for survival.
But why is this specific physiology so incredibly relevant to the anesthetist who's about to push a syringe of propofol?
Because every single one of our anesthetic drugs profoundly disrupts these compensatory mechanisms. Think about it. Your chronic hypertensive patient is walking around in a compensated state. They're relying on high sympathetic tone and a clamped down RAAS just to maintain their pressure against gravity.
They're already on a knife edge.
A razor's edge. You come along and push propofol. What does it do? It's a sympatholytic. It's a vasodilator. You instantly knock out that sympathetic tone. Suddenly, the entire scaffolding that was holding their blood pressure up collapses.
And that's the mechanism of that severe precipitous induction hypotension.
That's exactly it. You've kicked out the props from under them.
That segues perfectly into our next section, Section 3. The pathophysiology of hypertension. The outline labels this as absolutely essential. So when we say a patient has hypertension, what is actually broken in that system?
In 90 to 95% of cases, we're talking about essential hypertension. And in these patients, the primary fundamental defect is an increase in systemic vascular resistance.
So the vessels are just clamped down too tight?
That's right. For a given cardiac output, their resistance is inappropriately high. Cardiac output itself is usually normal or even a bit low.
Okay, so why? What's causing this increased SVR?
It's multifactorial, and you should list a few key mechanisms. First, sympathetic overactivity. For reasons we don't fully understand, these patients often have higher circulating levels of catecholamines like norepinephrine, or their adrenergic receptors are upregulated. They're just super sensitive to any stress.
So they overreact to stimuli.
A massive overreaction. Second is the RAAS, which we just talked about. In many hypertensive patients, this system is inappropriately active. It's releasing renin even when the blood pressure is already high.
The feedback loop is broken.
The feedback loop is broken. And third, and this is a key concept for modern understanding, is endothelial dysfunction.
Tell me more about that.
The endothelium, the inner lining of the blood vessel, isn't just a passive barrier. It's an active organ. It's supposed to release substances like nitric oxide to relax the vessel, smooth muscle. In hypertension, it fails to do so. The balance is tipped towards vasoconstriction.
And over time, this causes physical changes to the vessel itself.
Yes, this leads to vascular remodeling. The vessel walls thicken, they hypertrophy. This is called arterial sclerosis. The lumen, the inside of the pipe, gets permanently smaller. So even at baseline, their SVR is structurally high.
There's a concept in the outline called baroreceptor resetting. This feels like a classic exam trap.
It's not just a trap. It's arguably the most important concept for understanding intraoperative management.
Yeah.
If you grasp this, you understand why we do what we do.
Okay, break it down for me.
Think of the baroreceptor system as a thermostat in your house. Normally, it's set to maintain your blood pressure at, say, 12/20/80. If your pressure goes up to 150, the baroreceptors fire like crazy, and the body works hard to bring it back down. In chronic hypertension, that thermostat gets broken. The baroreceptors are constantly being bombarded by high pressure, and eventually they just give up fighting it. They reset to a higher set point. They start to think that 160/90 is the new normal.
So they actually start to defend the high pressure.
Exactly. They defend it as if it were necessary for survival. That is the absolute danger for us. If you, the anesthetist, see 160/90 and rapidly drop the pressure to a textbook normal of 12/80, what do the patient's baroreceptors perceive?
They see it as severe hypotension.
They scream shock. They trigger a massive, unopposed, sympathetic surge tachycardia vasoconstriction to try and get the pressure back up to what they now consider normal.
And that explains why we never aim for a textbook 20/80 in a chronic hypertensive patient. We're literally fighting their own reflexes.
Precisely. You have to respect the reset. Your goal is to keep them within a narrow band of their new, albeit pathological, normal.
That makes so much sense. Okay, moving on to section 4, classification of hypertension. The outline says this must be systematic.
In an exam, structure is everything. You can't just throw out facts. You need a framework. For classification, you start with the etiological classification.
Which is primary versus secondary.
Correct. You state that primary or essential hypertension is idiopathic. We don't know the exact cause, and it accounts for the vast majority, 90 to 95% of all cases. Then you say secondary hypertension has a specific, identifiable, and often correctable cause.
Okay, so etiology first, then what?
Then you classify based on severity, and here you go back to quoting the numbers. You have to have the JNC7 classification memorized cold.
Let's run through them one more time just to lock it in.
Absolutely. Normal. Systolic less than 120 Andy, diastolic less than 80.
Pre-hypertension.
That's a systolic of 120 to 139 OR, a diastolic of 80 to 89,
Stage 1 hypertension.
140 to 159 systolic or R, 90 to 99 diastolic.
And stage 2.
Anything greater than or equal to 160 systolic or R, greater than or equal to 100 diastolic.
And when you're presenting this to an examiner,
you are crisp. You don't fumble the numbers. You say, sir, based on the readings, and according to JNC7 criteria, this patient falls into stage 2 hypertension. It just shows confidence in preparation.
Perfect. Now, let's dig into that smaller group. Section 5, causes of secondary hypertension. This is labeled as a very high yield for Vivas.
It is, because it shows you can think like a physician, not just an anesthetist. Again, you need to categorize your answer. If you just list random diseases, you sound disorganized.
So what are the headings?
Use the classic mnemonic. READ, renal, endocrine, aortic, and drugs.
Okay, let's hit renal first.
It is the single most common cause of secondary hypertension. So you lead with it. You're looking at things like chronic renal failure, renal artery stenosis, especially in a patient with new flash, pulmonary edema, and glomerulonephritis.
So if you see a young person with very high blood pressure,
You have to think about the kidneys first.
okay, E for endocrine. This is where the really interesting classic pathology lies, isn't it?
Absolutely. The classic one, the one you must know about, is Pheochromocytoma.
A tumor of the adrenal medulla.
Right, secreting massive amounts of excess catecholamines. For the exam, you must know the classic triad of symptoms.
Paroxysms of headache, sweating, and tachycardia. The 3 Ps, pain, perspiration, palpitations.
Excellent. You say that and you've scored a point.
Why is Pheo so critical for us in anesthesia?
Because if you miss it, you can kill the patient on the table. Simple as that. Many of our drugs, like morphine or atracurium, which release histamine, or any physical manipulation of the tumor during surgery, can trigger a massive lethal hypertensive crisis.
So you have to know about it to manage it.
You have to, and you have to know the rule of management. Alpha blockade before beta blockade. Always.
What else in the endocrine category?
Think about primary hyperaldosteronism, or Conn's syndrome. The clue there is hypertension paired with unexplained hypokalemia.
Low potassium.
Right. Then there's Cushing's syndrome, excess glucocorticoids. And don't forget thyroid disorders. Hyperthyroidism tends to cause a wide pulse pressure, a high systolic hypertension.
And hypothyroidism. Classically, that causes diastolic hypertension. The vessels are just stiff and constricted.
Okay, so that's renal, endocrine. A is for aortic.
Specifically, coarctation of the aorta, a narrowing of the aorta usually just after the subclavian artery.
And the classic exam finding for that.
Hypertension in the upper limbs, but weak, delayed, or absent pulses in the femoral arteries. Radiofemoral delay. It's why you should always palpate the femoral pulses in any new hypertensive patient you evaluate.
Good clinical pearl. And finally, D for drugs.
Always take a thorough drug history. You'd be amazed how often this is the cause. Estrogens and oral contraceptive pills.
Steroids.
Yep. NSAIDs, many people don't realize they cause significant sodium and water retention. And of course, sympathomimetics.
Like cocaine, amphetamines, even over-the-counter diet pills and decongestants.
Exactly. Even something as benign-sounding as licorice, if consumed in large quantities, can cause a similar picture to hyperaldosteronism.
So what's the ultimate anesthetic relevance of sorting through all these secondary causes?
Because the management changes dramatically based on the cause. If it's renal disease, your fluid management becomes incredibly tricky. If it's Pheochromocytoma, you need specific alpha and beta blockers. If it's drug-induced, the answer is to stop the offending drug. You must actively rule these out during your pre-anesthetic checkup.
That makes sense. Let's move to section 6, target organ damage. The sources are really clear on this. Treating the number on the monitor while ignoring the damage to the organs is a guaranteed fail.
It's the biggest mistake a junior resident can make. Hypertension is a systemic disease. The high pressure is just a symptom. The disease is what's happening to the end organs. You need to systematically scan 4 key systems.
What?
The cardiovascular system, the central nervous system, the kidneys, and the eyes.
Let's break those down. What are we looking for in the cardiovascular system?
You are actively hunting for signs of left ventricular hypertrophy, or LVH. You're looking for evidence of coronary artery disease and signs of heart failure, both systolic and diastolic. We'll do a much deeper dive into LVH in the next section because it's so important.
Okay. CNS. The brain.
Obviously, we're looking for a history of cerebrovascular disease, stroke, transient ischemic attacks, TIAs. But the gold star concept here, the one that really separates the top candidates from the rest, is demonstrating your understanding of the shift of the cerebral autoregulation curve.
I want to spend a minute on this. This feels absolutely critical for intraoperative management.
It is the single most important physiological adaptation to understand.
Yeah.
Normally, your brain is incredibly good at maintaining constant blood flow despite wide swings in your systemic blood pressure. It does this between a mean arterial pressure, or MAP, of roughly 50 and 150 millimeters of mercury.
The autoregulatory plateau.
Correct. But in chronic hypertension, to protect the delicate brain capillaries from those dangerously high pressures, the cerebral arterioles hypertrophy. They thicken their walls. And as a result, the entire curve shifts to the right.
So that plateau moves. The lower limit is no longer 50.
The lower limit might now be 100 or even 110. This is the crucial part. This means if you, the anesthetist, allow their MAP to drop to, say, 70, which is a perfectly acceptable MAP for you or me, your hypertensive patient has fallen off the left edge of their curve.
And their brain vessels can't dilate enough to maintain flow.
They're already maximally dilated, flow becomes pressure dependent, and it plummets. They get cerebral ischemia, a watershed stroke.
That is terrifying. You could literally cause a stroke while the monitor is reading a number you think is normal or even just a little low.
Precisely. And that is why we say relative hypotension is what's dangerous, not absolute numbers. It's all relative to their new shifted baseline.
Okay, that's a huge takeaway. What about the kidneys?
For the kidneys, you're looking for evidence of nephropathy.
Yep.
Look at the labs, an elevated creatinine or BUN. Look at the urinalysis for proteinuria. Specifically, microalbuminuria is a very early sign of glomerular damage.
And finally, the eyes.
The retina is the only place in the body where you can directly visualize arterioles. So a fundoscopy gives you a window into the state of the patient's entire microcirculation.
And what do you see?
You see hypertensive retinopathy. It's graded from I to IV. You start with arteriolar narrowing, then you see AV nicking where the skiff arteries compress the veins. Later you get hemorrhages, cotton wool spots, hard exudates, and in the most severe form, papilledema swelling of the optic disc. That's a sign of a hypertensive emergency.
Okay, let's circle back to the heart because the outline has a whole section on it. Section 7, cardiovascular changes in chronic hypertension, labeled exam gold. Why is left ventricular hypertrophy so bad?
Because it fundamentally changes the structure and function of the heart. The left ventricle has to pump blood out against a chronically high systemic vascular resistance, a high afterload. Like any muscle that works against resistance, it gets bigger.
It bulks up.
It bulks up, but it thickens inward. This is called concentric hypertrophy. So the chamber size actually gets smaller and the wall becomes incredibly thick and stiff.
Stiffer means it's harder to fill.
Exactly. This is the definition of diastolic dysfunction. The heart cannot relax properly during diastole to allow blood to fill it from the atrium. Filling becomes difficult and requires higher atrial pressures.
And this makes the heart more dependent on that last bit of filling from the atrium contracting.
It becomes critically dependent on the atrial kick. In a healthy heart, the atrial kick contributes maybe 15 to 20% of ventricular filling. In a patient with severe LVH, it can be as much as 30 or even 40%.
So if they lose that kick, say they go into atrial fibrillation.
They decompensate catastrophically. Their cardiac output plummets. They go into acute hypotension and flash pulmonary edema. These patients do not tolerate the loss of a normal sinus rhythm.
And what about the coronary arteries? What's happening with the heart's own blood supply?
It's a classic supply and demand mismatch. That huge, thick muscle mass needs way more oxygen, so demand is way up, but the supply is compromised. Coronary arteries fill during diastole. In these patients, the high pressure inside the thick ventricular wall literally squeezes the coronary vessels shut during systole. And that high wall tension makes it harder for them to fill in diastole.
So they're starved for oxygen, even at baseline.
They are prone to subendocardial ischemia, even without any significant coronary artery plaques.
And the main anesthetic implication from all of this?
They do not tolerate tachycardia. Tachycardia is the enemy. It dramatically increases oxygen demand while simultaneously shortening diastolic time, which is the only time the coronaries can fill. It's a recipe for an MI on the table.